Welcome, everyone, to Beauty and the Surgeon podcast. I'm Amy. I'm a nutritional therapy practitioner, and I'm joined today, as always, by my fantastic co-host.
Very fantastic.
Dr. Jason Martin. He's a board-certified plastic and reconstructive surgeon. Dr. Martin, how you doing?
I'm doing really good, Amy. How are you doing today?
I'm doing good. We have a great episode today. Before we get too far into it, I always forget to mention that there are timestamps. So if you're interested in just hearing about one aspect of this procedure that we're about to discuss, you can find those in the description box below, along with the link to find a board-certified plastic surgeon near you, which definitely look that up. We'll be talking more about that in this episode. All of our social media links are here. You can find us everywhere at Beauty and the Surgeon podcast and at Jason Martin MD. We're also on YouTube if you'd like to watch the video that goes along with this podcast. You know, something that I did want to bring up is there is actually a really great, I don't know if most people know about this, but YouTube has YouTube Music app, and you can watch and listen to all of our podcast episodes there as well, which is really cool. And you can listen to it in the background. So you can have it turned off. You can pick just audio. You can go back and forth between audio and video. So if you're listening on audio and all of a sudden we say something cool and you want to see it, you just switch it back to video and there's the slide. So
Amy gets very frustrated with me because I listen to the podcast on YouTube playing a video, you know?
But you only listen to the audio.
Yeah.
Yeah, so you don't have to. So get the YouTube Music
I know,
app.
she always says this.
Yes, and then you can go back and forth. So,
I have to do it different.
Yes. So you can find us everywhere. Dr. Martin, we have a great topic today that we've talked about before, but never really done a two-parter like deep dive like we're going to do.
Right. It's one of the most common surgeries we do. So
I would actually disagree with that. It's the most common. It's
one of the most.
It's pretty far up
across the United States.
Well, we're going to look at the statistics.
All right.
So let me tell everybody what it is before we stomp all over it. So we're talking about everything you need to know about breast reduction, which you probably saw from the title. This is part one. In part one, we're going to discuss who the surgery is a good fit for, if you're a candidate, and all the way up until your initial consultation with your surgeon. Part two, we're going to start off with pre-op and go all the way through recovery. So this is the everything leading up to your pre-op appointment. In part two, we're going to cover everything from your pre-op appointment all the way until you are literally loving your fabulous smaller breasts. So Dr. Martin, since you were talking about statistics, let's talk about statistics.
Oh, no, you got to prove me wrong here or no?
No, I'm just saying for us personally as a practice, it's not the most popular procedure we do. And it definitely is not.
It's actually not a lot.
No, it's not.
That's interesting.
And this is, remember, when we look at these statistics, this is from board certified plastic surgeons, and this is for aesthetic patients only. So this is not including perhaps some insurance related numbers, which we will talk about in this episode as well.
So just theoretically speaking, I know you're going to go through this, but if you included the insurance numbers, don't you think it would be one of the more common surgeries we do in plastic surgery?
No, not even close.
Okay, it's interesting.
I mean, so Dr. Martin, how many breast dogs were done in 2020?
Yeah, like 150,000.
Yeah, close to 200,000.
Yeah.
I mean, and this is 33,000. So absolutely not. Do I think it is one of the top procedures in plastic surgery? No, because there are far more popular things like breast dog and liposuction, even facelifts. But it is definitely a surgery that has an amazing niche of a population who is an amazing candidate for it. And the results, I mean, we say this on our previous episodes about breast reduction, probably one of the most rewarding surgeries we do because the patients are universally the happiest.
Yep. It has a functional benefit and it has an aesthetic benefit. And there's not many surgeries we do that are like that. And the functional benefit for breast reduction,
which we will talk about,
is remarkable. So that alone can make patients happy, not just like how your breasts look. They're not heavy anymore. You look better in clothing, etc. So I think it's a great surgery. It's very transformative. Patients are very happy.
It is. Yeah. So a breast reduction, we're going to try really hard in this episode not to just stomp all over breast lift and really focus just on breast reduction. There are a lot of similarities. We'll do a big two-parter on breast lift at some point, but just know that there are similarities. But a breast reduction includes a lift in almost all cases, but is different than a lift. And that's why we'll try not to say like a lift. We're just going to stick with just breast reduction in this if we can.
She's talking to me right now.
I'm talking to myself too, because it is so tempting. You know, it's like, oh, just like a lift.
Because it really is very similar, but there is some big differences between the two.
But we'll try our best for those of you ladies out there listening who want to hear just about breast reduction. So what can a breast reduction do? Can remove excess breast skin or breast fat, glandular tissue, and skin to achieve a breast that's more proportional to the size of your body.
Right. Breast reductions alone are about bringing balance back to your body, period.
And physical comfort as well, which we will talk more about. Something else that we often do with a breast reduction.
Yeah, is reduce the areola size. People with large breasts tend to have very large areolas. And the more ptotic, the more droopy the breasts are, the bigger the areola usually get. So that's one silver lining of these surgeries that people don't really consider when they think they want a breast reduction. So reduced areola size.
Yeah. And like you said, the more droopiness there is, it does tend to become even larger with
So can we test Amy? Nils, grab the microphone. What is the normal diameter of an areola? When I say normal, the one I use.
There is no normal.
The one that I use.
The one you use is like a 20 centimeter?
No, it's 3.20 centimeters. You didn't mean that. But it's 3.8 centimeters of what I use. Sorry, so I didn't give you a chance.
Millimeters.
Yeah.
Yes, millimeters. Yeah, millimeters. Sorry.
It'd be the whole breast.
I was about right. So it is. We have had patients who have felt.
What is like 3 centimeters? What would that be in inches?
Like 2?
Yeah, about 2 inches.
2?
Yeah.
Mm-hmm. Yeah, with Nils, just Nils. I feel like you're basically in the metric system.
What are the size of your areola, please?
And to be fair, I mean, that is a little bit small for some patients. So it doesn't have to be that small. This is a conversation your surgeon would have with you. One of the big things that Dr. Martin mentioned was alleviating pain and discomfort associated with large breasts. Something else that I think is so key. Dr. Martin, will you talk about this one?
Yeah, improve self-image. The self-consciousness that people feel with large breasts, especially in younger patients. And we see this all the time in young women that are 18, 19, 20. But as you get older,
even like under 30, I feel like it really plays with your...
It starts to define who you are. They can't wear certain clothing. It really becomes a hindrance. And it's frustrating for them. And we feel for them. I mean, you feel it when they come in and they tell you how they feel about their breasts. And it's amazing, by removing the weight of the breast, you remove this weight on you almost psychologically in your mind.
Even physically. It does allow to have better aspiration. You can breathe more easily without all this weight on your chest.
This weight's gone. You're more active, have an active lifestyle. You're going to do more things, especially when you're younger. You're going to be more adventurous. You're going to feel that your life literally has more possibilities because you're not weighed down by these large breasts. Yeah. What's the last one here, Amy?
Well, before that, I want to talk a little bit more about self-consciousness because I can speak on this as a woman, especially a young woman. That we live in a society that does tend to over-sexualize women, and especially now with social media, it really does. So when your breasts are the first and only thing maybe that people notice and or value you for, that really can mess with your head as a young person. Mm-hmm. So it's not uncommon that we get, parents calling for their daughters who are even like as young as 16 because their breasts are already so overdeveloped. So it can start young, and it can really mess with somebody's head for a lot of reasons. I feel like social media even emphasizes that even more so.
Yeah.
So the last thing on my list here, 3 little words: button up shirts.
So I'm sorry to interrupt, but I literally did a breast reduction 2 weeks ago, and the woman brought a button-up shirt so she could wear it afterwards. I went to see her after surgery, and she's like, "Look at the shirt I'm wearing." I had no idea what she was saying. It was a button-up shirt that she could never wear.
Yeah, because the gapping. I mean, they don't even try.
Right.
And it just opens up a world of clothing choices. So many of these women, too, when your breasts are so large in proportion to your waist, everything makes you look heavy. You end up looking like a tent in everything you wear, because if it doesn't, you're not trying to be vamping it up and have everything be super tight across your chest, but then it just like drapes the rest of you with all this extra fabric. So
she was of normal size, had size G breast.
Yeah.
Yeah.
Yep.
Can I say one thing about the pain and discomfort? Mm-hmm. So if you have large breasts, and we've talked about this on the previous episode, there's a couple things that go on. The whole functioning of your torso changes, especially the upper torso, the thoracic spine, the cervical spine. So that's the upper spine. You get this kyphotic stance,
which is like a hunchback.
Which is Amy's always addressing my kyphosis because of surgery. If you're watching on the YouTube channel, you tend to bend over. Grooving in the shoulders
we'll talk about that too.
Is really common. And I mean, we've had patients that are so severe that they'll have numbness shooting down their arms. I mean, the physical ramifications of large breasts are real and are not going to go away unless those breasts are reduced in size.
Yeah, spot reducing breast tissue is not really possible. And we'll talk more about some of the things that can... Actually, our very next slide. So let's just go to our next slide. So
remember, we also had our listener from last episode who'd hit her boob on the door.
Right.
So
yes.
That sounds painful,
I believe it was.
too.
Yes. I believe it was bash a boob.
Bash a boob on the door.
That's a very good memory.
That's when I got my fembots. Yeah. So there are a couple of things that a breast reduction will not or cannot do, and that is to stop the aging process. Your breasts will continue to age or droop with your lifetime, and normal hormone fluctuations. As Dr. Martin mentioned, we often do the surgery on women who are under 30, who are going to have pregnancies and other normal hormonal changes in their life. Even patients, we'll find when they go through menopause, sometimes their breast tissue will kind of spontaneously regrow. And we do a breast reduction again on women in their 50s and 60s.
We've had multiple patients where we have done a breast reduction in their 40s, 50s, and 60s, exactly what Amy's talking about.
Yeah. Or who had it, when they were 18, 19, somewhere else, and then have had a baby and now their breasts are back again. So those things will still happen and they will still impact your breasts. So it will not prevent you from needing a future breast lift. Maybe you just need a lift in the future because your breasts just got droopy from pregnancy, but they're not huge anymore. They just need to be lifted. So you will still probably have normal aging of your breasts. Most women, by the time they're in their 40s and 50s, most women could benefit from a breast lift, and having a breast reduction is not going to mean that you don't need that potentially in the future.
Right.
Yeah. So let's talk about who's a good candidate. This is where we're going to talk more about a lot of the physical symptoms that come up with having large breasts. Number one, healthy enough for surgery and you're a non-smoker, non-vapor. That's with any surgery. I literally just keep those on the slides because that is the same with any surgery we do. Having realistic expectations and specific goals for breast reduction is key for some reasons that we'll talk about in the future. There are limitations with breast reduction about what can be accomplished, but, you obviously feel like your breasts are too large, obviously, that as well. So
like when you say limitations, you mean how small you can go, or is that what are you saying how much you can lift the breast? What are your limitations?
Correct. Okay. And that's what we'll talk about in future episodes. But Dr. When you were talking about some of these things that it can cause, let's go into it a little bit deeper, because you mentioned some of just the weight of the breast, but the grooving, but then also there's a couple other things we didn't really cover.
So there's kind of a checklist actually when you run it through insurance, and this is more about the aesthetic part. Oh, okay.
I have a slide for that.
Oh, perfect.
Yes, I do.
I knew she did.
I have a slide for that. So we'll go to the next slide.
Okay.
About will insurance cover it, and we'll talk about some of the things that you need to meet, which is this complementary and alternative medicine.
Right. And it's a pretty extensive list for most insurance carriers. Now, this is not the insurance breast reduction insurance episode.
Nope.
Because every carrier is different. Every insurance policy is different for patients, but in general, you have to have the physical manifestation, the back pain, the shoulder pain, the grooving in the shoulders, physical things that are actually present. You have to have had a history of actually interventions to make yourself feel better. That would be physical therapy. That would be using ibuprofen or non-steroidals for pain for a long period of time. It could even be acupuncture and some alternative therapies, as Amy put in here, going to the chiropractor, occupational therapy, physical therapy. You actually have skin changes. You can have, what do they call that? When the abrasions that occur underneath the breast. You can have fungal infections there with the way your breasts sit down.
Yep. Fungal and yeast infections from the skin on skin.
So I highly advise people, if you're interested in the surgery and you're really thinking you want it through insurance, is actually do your own research and see what the criteria are to be met. The other part of it is your BMI. Amy and I, and everyone that does this, feels that BMI is probably not the best option, but it's what we use. So Amy, how would you describe BMI? I know we've done that before. But
yeah, just based on your height and weight.
Yeah.
So it's just a calculation of your height and your weight.
Of your body mass, and it uses surface area too. Yep. So basically, if your BMI is elevated, if you're very obese or morbidly obese, a lot of times they won't approve this surgery. There is some changes as your height goes down. So if you get really low height and your BMI is high, they might let you do the surgery. And then the other part of it is the SNR calculation, which I'm still not sure exactly how we do this, but we do it every time.
Well, it's based on its surface area.
I know it's surface area, but so anyways, they'll have a SNR criteria for your height and weight for your BMI.
Yeah, there's a little picture of it. This is showing where you are, body surface area versus the grams removed, which I'll touch on as well.
Yeah. So when you go into the surgeon's office, and they're thinking they're going to run this through insurance, they're going to do the BMI calculations, they're going to do a SNR calculation. Then they're going to say, the surgeon's going to say, yeah, I can take out this many grams. I can take out 600 grams, 700 grams, 800 grams, looking at your physical exam. And it seems very arbitrary, and it is, but this is the system we have in place for running it through insurance. But if you take a step back from that for a second, the realities of large breasts, what we keep saying over and over is all these physical presentations that you see. And you don't
impact your daily life.
Like just normal activities, work activities.
Even sleeping.
Sleeping, intimacy, everything these people do, it's affected by these large breasts. And that has downstream effects on their health, on their ability to go to work, on their ability to do normal human activities and enjoyment and all these things. So this is like a carve out for aesthetic procedures that we don't always see. If you have a aging of the face, not like Amy has, like I have. There's no physical problems that I'm dealing with. This
I got physical problems with the aging of my face.
I saw that one coming. But these breasts have a real life affecting part of it. And that's where the surgery makes the biggest difference. So, and that's where I think this is truly a special surgery in that sense. There's only a few like these. We've mentioned this before: paniculectomy, maybe thigh lift, right?
Mm-hmm. Yep,
maybe brachioplasty sometimes. But breast reduction, I think, it's pretty crazy how much it changes people's lives.
Yeah. So to give you guys a little breakdown of what it's like to have things covered by insurance. Number one, you have to make sure that this is actually even a covered service by your insurance provider. And there are many insurance companies. Your employer can also opt out of certain procedures. So it's not necessarily covered. Even if it is covered, it can still be very challenging to get it approved because you do have to meet specific requirements. There are some insurance companies require that you do X amount of things, like that you have to have had at least like 30 chiropractor visits, or
there's some that require an MRI of the spine,
a
CT of the spine.
Yeah, I was just going to go to that one too.
Yeah.
That you've been to a pain management specialist. So you may have had to go through years of being referred out to, okay, chiropractic couldn't do it. They've taken tons of x-rays. They send you for the MRI. The MRI gets you to the pain management specialist.
What are the copays on all these things? How much money is the person spending just to get to the point where they can pay another copay to pay for the surgery? So it's a lot of work.
Yep. And dermatology as well. So if you have things like rashes, they're not just going to take your word for it. Like, you actually then have to have notes that prove that you've been to a dermatologist. The dermatologist has seen your rash. You've tried these antifungal treatments.
And they're going to want to see photographs of your breast and also the grooving in your shoulders. And these are all the things that are going to be submitted. And then there's a likelihood they'll turn it down. And then the surgeon and the staff has to go back, almost like renegotiate with the insurance company again. So it's not an easy process.
Yeah, and those are in cases where you actually
are covered.
Do get covered. Yeah. Even then, and this is just to give everybody the very real truth here, even if you get it approved, let's say your surgeon doesn't remove as much breast tissue as they thought they would, they could still come back and retroactively deny it because you didn't actually meet the requirements. So the more research and the more, my point to all of this is that you need to be a good advocate for yourself, but you also need to do all this work ahead of time. So this is a lot on you, the patient. You need to make sure you've done these things. You need to bring these notes with you to your surgeon's office. You need to call your insurance company and make sure that it's even a covered procedure. Because if you go through all of this and it's just not covered at all under any circumstances, that's a lot of, like Dr. Martin said, a lot of money you've spent, a lot of time, a lot of, energy and effort.
So mental energy, emotional energy. So this is one of those situations, as Amy says, you have to be your own advocate and you have to really be proactive even before you go into the surgeon's office. And I think that's really important. I think that's a good point.
Yeah. And if you do get in that situation where your insurance is not covered, the following year, you can either, your employer, if you work for a large company and it's denied under their particular policy standards, that's where you need to talk to your HR department. Like, go talk to them, explain to them the problems you're having, like implore upon them to, when they renew, to have this be a covered service. And, or, this is where we do have the option to go third party. And, if it's really important and you really need to get it covered, at that point, you have to then weigh the cost benefit. This is something that you can choose to self-pay for. So we'll talk a little bit more about that as well when we get back from our break. We're going to take a quick break and we'll be back in just a moment. We're back.
I feel like calculating the SNR is like me trying to calculate what I'm paying in taxes.
Well, luckily, just like our bookkeeper, our accountant does for us, our EMR calculates the SNR for us.
Thank you.
And
Thank you, EMR.
There are SNR calculators online. If you just do a quick Google search, like, you can actually type in your height and weight and it'll tell you what your SNR is. So that doesn't really do a whole lot because all it's going to tell you is how many grams would need to be removed. And most of us don't have a good ability to understand that.
At least you have some information there.
You do, but you still need to have a surgeon tell you whether or not that's realistic for you.
Yeah.
So,
and that's critical. So if the SNR says 800 grams and you're 5'2", 120 pounds and you have large breasts, but they're nowhere near 800 grams, that may not mean anything to you, but it's not going to work. Then you're going to have to pay out of pocket and go to someone for the reduction that would be considered cosmetic.
Right. Or we have had, in rare cases, we've had a patient come to us who truly feels that their breasts are extremely large. And on a, scale of normal sized women, which we see many of every day, their breasts are actually very normal sized, but in their mind, they're so big and so cumbersome. And for whatever reason, in those cases, obviously insurance won't cover it, but we'll still, do as much for reduction as we can. And
right. And do a lift.
Yeah. And do a lift.
I'm not allowed to say lift though.
No, we're trying not to stomp on lifts. So let's talk about the 3 different kind of main types of breast reduction. I'm going to go through them, and then Dr. Moore will kind of talk about them in more detail. We do have some pictures that we're kind of showing the 2 main types is the lollipop, so around the areola and straight down, and then an anchor or a keyhole. And then there's also an extended anchor or just an extended in general, where we're extending it underneath into the armpit area and even maybe across the back, just if there's a lot of redundant skin that goes around the sides. Dr. Martin, I didn't put Wise pattern on here or inferior, super, pedicle, all those other words, but will you kind of...
But why didn't you?
Right? I think it is kind of critical to explain, why would you need to do the keyhole with the anchor versus the lollipop alone?
All right. So... can I make it even more simple than that?
Yeah, you make it as simple as you want.
So this is, imagine a lollipop. So all the listeners, not the viewers. Okay. So a lollipop. So you're taking tissue out around your areola and down the midline of the breast. And so you're taking it out and closing in a vertical fashion, like the incisions go vertically. So you're narrowing the breast. But there's a lot of women with large breasts that don't just have redundancy in a width standpoint, they have redundancy in an up and down standpoint. They have very large breasts that are droopy. There is inches of tissue that go down. Clearly, you can't chase that out in a vertical fashion. You also have to chase it out horizontally. One of the things you see in large breasts is the inframammary fold. Amy, how would you say that? What's the layperson way to say inframammary fold? Where the breast meets the chest wall.
Yeah, and I would say inframammary fold is kind of like luteal fold. I think people get what that is.
Okay.
I think enough people understand what that is. Yeah.
I'm with you. So, if that inframammary fold is almost to your belly button, you can't lift. It's really hard to lift that back up just using a lollipop. So that Wise pattern where you not only do a vertical incision around your areola, but you do something along the base of your breast, is chasing out that extra tissue both in a horizontal and vertical direction. And to get to these weights, especially for insurance, a lot of times you just have to automatically go to that anchor incision. You can't even do the vertical or the lollipop.
Well, and you're really with that, with most women, I think realize where they want to get rid of the weight and the heaviness. Well, that's all below. So that's why you need that incision below to be able to really get rid of all of that as well and to pull everything back up. We're trying to maintain fullness in the upper pole of the breast, which we can do with kind of utilizing some of your own tissue, which we will talk about in more detail when we talk about how the surgery is performed. That's in part 2. I'm teasing part 2. So if you want to hear about how we do surgery and how
part 2 is
the
so
magic,
good, even though we haven't recorded it yet.
Dr. Martin's
going to so amazing.
Talk about the magic of tissue rotation in part 2.
Like and subscribe.
But I think most women, and this is in our experience only, who are doing a breast reduction don't care about the scars one bit.
Yeah, that's true.
And the scar doesn't, and I say this to people, the visible part of the scar is there no matter what. So people get caught up on this whole anchor part, oh, do I have to have that? That literally is hidden.
It's hidden in the crease.
Yes. The only part that's visible is the lollipop. So
yeah, I mean, it's funny. Historically, there was a lady named Hall Finlay. She's in Banff, and we always talk about Banff because I want to go there. I've never been.
You've never been to Banff?
No, I've never been.
Oh, it's gorgeous.
Yeah, I always look at pictures. And she it was early mid 2000s, where she came out and brought out this kind of vertical reduction, and the way that you can do it vertically or through the lollipop incision. And it's really good, but it's really only for people that need a small reduction. If you need a larger reduction, something that's sizable, something that's going to have a consequence in your life physically, you're probably going to have to add the anchor in there too.
Yeah.
And if you don't add the anchor, then you're going to have this janky vertical scar that then goes into your fold and curves over like a J.
Yeah.
Very hard to understand. I wouldn't even draw it out for you. Yeah.
It always tethers.
And then if you're doing that already, then you just go to the anchor. So again, there's themes in this podcast for us with AB and I, but you please don't get stuck on the scars. Get the surgery you need. If you have really large breasts and a lot of redundancy of skin and breast tissue and soft tissue below your nipple and areola that hang way down, you need the anchor incision. Pretty much. You're not going to get around it. If you have really redundant skin, a lot of laxity, you need the anchor. If you need to reach a certain weight, you probably need the anchor. And to be honest with you,
for the best aesthetic outcome,
in very large breasts, you got to do the anchor just for safety purposes to maintain the nipple and areola. So you're going to think in your mind maybe 10 to 20% you can do a true vertical. And in most cases, those are probably not going to be insurance covered. There's going to be more for aesthetic reasons. Now,
or for very young women who have like really good skin integrity.
Right.
Yeah.
And the word I can't say, lift. I do those true verticals or lollipops all the time. And that makes sense. But that sometimes I'll do an anchor on that. But that makes sense because I don't have to remove as much tissue. And that makes sense. In most cases, I'm probably, at least in our practice, could be adding an implant, adding volume back in. So don't
say implant on an episode about breast reduction.
Yeah, there's a big difference.
They do not want to hear that.
Yeah.
Like they do not.
We've done an implant on someone who had a reduction when they were really young and lost a lot of weight over life.
Yeah.
Yeah.
Yeah, you can always add volume back in. One other thing that with the extended anchor, a lot of women also have almost like this axillary breast tissue, like breast tissue that's in their armpit, because that breast tissue just grows so rapidly during puberty that it grows kind of even maybe outside where the normal breast is. It's all under their arm.
Yeah.
And, that all has to be removed as well. Any of these areas that you leave it, and we talked about this on our episode about gynecomastia, like breast reduction for men.
I was going to say, I thought you were going to, that's so funny. I thought you were going to say brachioplasty.
No, breast tissue can, right?
I know.
Breast tissue can regrow. So if you leave breast tissue way out on the outside, you don't chase that out at the time of surgery and your breasts do grow again, as they will in your lifetime, that'll grow too. So getting the surgery, you need kind of the more aggressive approach in the first place is probably going to be the best approach.
So you take your fold, the inframammary fold, the base of your breast where it comes around to your chest wall, and you extend out to like below your armpit area. Mm-hmm. A lot of women, especially as they age, get redundancy there. And if you're of normal weight or higher weight, the fat can accumulate there, then you have loose skin. So if you do the reduction, you're left with this redundancy and extra volume on the sides. Here's the problem with that. Insurance doesn't always cover removal of that. You can extend the breast reduction over within a reasonable range, and then you're not doing something insurance companies don't want you to do. But they're not going to cover going all the way around or like extending to the back, right? Getting into a bra line plasty. And that's something you have to understand, that you may have to deal with that afterwards. During a breast reduction for insurance or cosmetic purposes, you can do liposuction there, but liposuction is not going to tighten really loose skin either. So this is a consequence. If you're going to make your breasts a lot better, you may be stuck with some issues out on the side.
Maybe.
Or you can deal with it.
Yeah. Yep. Yeah. So those are our main types. This is always one of the most important slides in any of our podcast episodes.
I don't think I've ever seen this slide on
choosing a surgeon. It is very important. And if you actually look at the plasticsurgery.org and look at their slide about the cost of surgery, specifically to breast reduction, they actually say that the cost of surgery is not is like lesser importance than finding a surgeon that you are comfortable with and having good surgery. The desire to kind of cheat it and go with a cheap surgeon, especially if you're paying out of pocket or like the only one that your insurance will take. If they're not the right fit for you, they're not the right fit for you. Now, your insurance will not cover surgery with any doctor who is not board certified. So you have to go to a board certified surgeon to have it covered by insurance. However, I would think that there probably are some general surgeons who maybe say they do breast reduction.
Especially in rural areas.
Mm-hmm.
In areas where there's not
hospitals.
Representation by plastic surgeons.
Yeah. So always make sure you do find a board certified plastic surgeon. As a reminder, there are no boards certified by the Board of Medical Specialties, which is who is the overseeing body of most of the boards in this country, that has cosmetic surgery in its name.
I feel like we should get t-shirts with that made up for you, Amy.
I feel like I should. We have an amazing episode, and I am going to ding this one because it should be, is our new beauty guide, How to Choose a Surgeon.
1 out of 5.
It is fantastic. So that's a really important thing. Results in aesthetics that match your desired outcome is also key.
Right. I get a lot of time with patients. So number one, insurance is a special carve out because they make you take a certain amount out. And that's the reason sometimes not to go through insurance, because you can't do a small reduction. You have to go within the rules that they provide or that they claim or write down. So if you pay out of pocket for a reduction, you can go with a smaller reduction. You don't have to stick with these SNR calculations. But aesthetically speaking, you may want to be a B. The doctor may want you to be a D. We don't like cup sizes. I'm using that as an example. And that's where it may not align. So it's really important for you to voice with agency exactly the type and size of breast that you want. I think that's important. Also, the surgeon will tell you that's possible or not possible. And that's usually the way it goes. Some people come in and say, I want A breast, and they have G's. That's not going to happen, right? So that's just not, you physically can't even do that surgery. You would have to do a mastectomy. So the reality of doing these surgeries is there are some limitations about how much you can reduce to.
Mm-hmm. Yep. And primarily someone you feel comfortable with. So definitely get, more than one consultation if possible. If there are more than one board certified plastic surgeon in your area, definitely see many or see several. Find one that you really feel comfortable with. So let's talk about the consultation. So you have gone on plasticsurgery.org. You have found your plastic surgeon. This is kind of what you can expect your consultation. Specifically, if you're going through insurance, there are a couple of things that will happen. And Dr. Byrne did mention these before, that they will need to take photographs and verify your height and weight. So this is not something that you might need to do if you're going in for a facelift consult. Like, we don't take pictures at your consultation. Or we might, but we're not really going to take big pictures. And these pictures, might seem a little bit invasive because they will be up close of your breasts and they will be of grooving in your shoulders. They might be of your posture, things that are different than what we would take.
Have you lift up your breast so you can
see the
take
rashes.
Pictures of the rash in your skin, the excoriations that are there. With your shirt off. So you have to be mentally prepared for this.
Yep. Which, again, for women who have been kind of trying to hide their breasts for years can be somewhat, scary. So that's why we tell people this ahead of time. So you'll do a full medical history, current medications, allergies, supplements, history of smoking or drug use, previous surgeries. If you've had, a history of a lot of women who have large breasts have also had a history of having multiple cysts because they have such dense breast tissue that every time they go in for, any type of breast exam, they're like, let's go get this checked. So if you've had lots of little biopsies or anything, you need to bring your full health history with you.
Right. Family history of breast cancer. If you've had a mammogram, up-to-date mammogram, are you following the rules with the mammogram or recommendations for the mammogram? So these things are really, really important. If you've had an abnormal mammogram, are you a candidate? And we'll talk about sending the breast tissue off at surgery in the next episode. But the reality of it is it gets into critical kind of understanding of what your past medical history is, especially a family history of breast cancer.
Yeah. And discussing your options and expected outcome. Also provide a quote, so this might be if you are not going to be a insurance patient. A lot of our patients just don't want to go through their insurance for whatever reason. They have a super high deductible. It's actually cheaper for them to pay out of pocket.
It literally is.
Yeah.
It's so sad.
I have a $10,000 deductible on my insurance, so it might behoove me to self-pay. So you'll get a quote. Go over the risks and potential complications, which we'll talk about more in our next episode. Look at before and after pictures of similar expected outcomes. And this is what's so key because I always tell people this, especially with breast surgeries, it is impossible to tell the overall size of a human when you look at these pictures. I have a whole slideshow where I show people pictures of women with all the same size implants, but they all look completely different because that's the same thing with breasts in general. Your breasts are unique to you.
So how tall are you, Amy?
I'm 5'11".
Yeah. Would you know that by looking on this video? You really wouldn't.
No. In fact, people sometimes say that I'm really tall because,
because I'm
sitting.
Tall.
Yeah, that makes you like 6'2".
Right. Well, or people be like, I actually showed a clip of the podcast to someone once and they're like, oh my gosh, your boss is huge. This was somebody who knew me in real life.
Yes.
I'm like, yeah, I'm big. Sitting, he has a much longer. I'm a lot of length.
That's why we don't show Nils. We don't put him on camera because he's jacked.
Here's Nils.
Wait, here's Nils.
Yeah. Gorgeous Nils.
And we don't get dinged for that anyway.
No, we can ding Nils all we want. Yeah. Nils. Dr. Brown has a high torso. So it really is better. And this is why when people want to see a lot of pictures before they come in for a consultation, I'm like, seeing pictures is great, but it's better to look at pictures with your surgeon or your surgical office because they can actually show you pictures of women like you and outcomes that you could expect. If you are that woman who is like a triple F versus someone who's maybe a double D, you both are candidates for reduction, but you're going to have very different outcomes.
Right.
So, and based on your body size overall.
And the limitations, surgically speaking, again, this will be next episode, but I think it's important to say this. If you're a triple F and really droopy, there's literally only so much you can do safely to do the surgery and maintain the nipple and areola. So as opposed to that double D person who it's not too droopy and not too heavy, the options are probably more for that person to reduce more. And that's frustrating for the person with really large breasts that just wants it done, wants it gone.
Yeah. These questions are in the description box below, but you should definitely print these out and bring these with you to your surgeon. Number 1, are you board certified? Am I a good candidate for this procedure? Yes or no? What surgical technique is recommended for me? These are things that they should be able to tell you. And why? Where will you perform my surgery? What are the risks and complications? Dr. Brown, I'll let you take the next half.
Will I be able to breastfeed? Such a huge and important question, especially for the young women. Sensation to the nipple and areola. We talk about this all the time. There's ways to do this where you can maintain some of these nerves, but it's not guaranteed.
And some women who have very large breasts have diminished sensation anyway.
Right, because of the hanginess. The nerves are already stretched out just from the weight. But some women that come in, nipple sensation is extremely important to them. It's part of their ethos. It's something that's critical to them. And we tell them, don't do it.
Yep.
If this is really important to you, do not do this surgery, even if you could benefit from it.
Yeah. Oh, yeah. And we've had women who,
they said no. They say, okay, thank you for being honest.
Fundamental part of my sex life. I will not give this up. Like, then you should not do this surgery.
You should not do the surgery until you're ready to. How are complications handled? This is like extremely important. And I know this is redundant. People that watch this all the time or listen, but this is so important because there are complications with breast reduction. Big raw area of surgery.
We'll talk about these on an episode too.
Hematoma, scar formation, nerve changes, infection, asymmetries, fat necrosis, fat loss. These are real things even in competent hands. And so you want to know that that surgeon is going to be by your side and also how that's handled, both financially and otherwise, just like how you get it scheduled. What do you do? What's the plan? How can I expect my breast to look and age over time? This is always the critical question because people feel like when they do the breast reduction, the breast is never going to change again. Like their whole body will change, but the breasts are going to stay perfect. And obviously that's not the case.
No. And we have this conversation with women who do breast augmentation. I mean, any surgery we do does not stop aging. So gravity will continue to impact your breasts. And so will other things like we discussed in the previous slide about hormones, pregnancy, weight changes. All of these things will affect your breasts.
Chemotherapy. I mean, anything that happens in life. Stress.
As with all things, like aging does affect our breasts, unfortunately, like gravity. I think the amount of times we've had a patient come in for breast reduction and like the things that they say about their breasts, like, you got to throw one over my shoulder or the bashing them into a wall. So
I had one patient tell me that she could put it underneath her armpits. You wouldn't even know she had breasts. They're that
big. Yeah.
And I was very alarmed.
Yeah. So those things, it won't come back to that extent, but you can definitely expect some changes as your breasts age along with you. So that's going to wrap it up for this episode. In part 2, we're going to start off with pre-op and go all the way through. We're going to really deep dive on risks and complications. It's a really important episode to listen to. And Dr. Martin's going to really talk more about the secret sauce of surgery itself.
So much sauce.
And recovery. So definitely tune in next time. We appreciate you all so much for listening. If you would do me a huge favor, if you've made it this far in the podcast, like first off, thank you so much.
Thank you.
But I have noticed in looking at the comments, which we've gotten so many more of recently, and here's our phone number if you want to leave me a voicemail or send me a text, 303-630-9038. Our last 2 episodes were actually were questions from listeners. Most of the people who leave questions are not subscribed. In fact, it's like 1% of the people who comment on our podcast are actually subscribed. So if you're listening on YouTube, this is for YouTube only, please hit that subscribe button. I know everybody says that, but it doesn't cost anything. And if you never listen to one of our episodes again, it's totally fine, but it would really help us out and I would be very appreciative. So thank you everyone so much for listening. Social media can be found here at Beauty and the Surgeon Podcast at Jason Martin MD, and we will see you back here for part 2.
Episode number 2 coming next.
Part 2.